All right, so buckle up, everybody, because today we are going deep. We're talking about a pharmacology presentation all the way back from 1950. One of you listeners sent it in, and let me tell you, this is like a real-time capsule into how mental and behavioral health treatment was understood back then.
Yeah, like stepping back in time almost.
Right. So our goal today is to sift through this historical document and see what kind of gems we can uncover. Like, what were these agents they were using? What were they trying to treat? What was the thinking behind it all? Should be interesting.
Definitely. And right off the bat, one thing that jumps out at you is this awareness that they weren't talking about cures.
Yeah, that's something that really struck me too. Even in 1950, they knew this was more about helping people to, live better, function better, improve their daily lives. It wasn't about eliminating the disorder, it was about managing it. That's pretty forward thinking, isn't it?
It is. And it really emphasizes, even back then, the complexity of mental illness. Not something you just fix with a pill.
Exactly. So then the presentation goes on to outline the main mental disorders they were using these agents for. First up, schizophrenia. And they actually already recognize different aspects of it, what they call positive symptoms, like the hallucinations, the delusions, the stuff that's maybe more obvious, and then the negative symptoms. So things like lack of motivation, flat affect. What really struck you about their initial ideas of what might even cause schizophrenia?
What's fascinating is you see this early glimmer of the idea of a biological basis. They were starting to suspect that there was some kind of fundamental biochemical problem going on, and they specifically mention dopamine and serotonin. Now, obviously, our understanding is so much more intricate today, but this focus on neurotransmitters, even back then, that was a huge shift, moving away from purely psychological or environmental explanations and towards, a biological basis for the condition.
Totally. Next one they covered was bipolar disorder. So, the swings between deep depression and those intense highs, what they call mania. And again, they were hinting at a biochemical imbalance here, but with this interesting added idea of neuronal overcompensation. Almost like the brain was trying to correct itself, but kind of overshooting the mark. Pretty nuanced for the time, don't you think?
Yeah, and it is this idea of the brain trying to find its balance, even if it results in these extreme shifts in mood. Shows a certain level of insight into the brain's self-regulatory mechanisms is pretty remarkable for that era. And again, the focus on a potential biochemical basis, reinforcing this emerging understanding that these weren't just, emotional or behavioral problems, something deeper was going on.
Absolutely. Then they talked about narcolepsy, where people experience excessive daytime sleepiness, and the presentation points to potential problems with REM sleep regulation. Pretty cool to see those early observations that foreshadow what we understand much better about sleep architecture today.
Oh, for sure. And what's even more remarkable is that even back in 1950, they were noticing a high prevalence of a specific HLA subtype, DQB10602, of
Mm-hmm.
people with narcolepsy.
Wow, that's really specific.
It is. And it's like this early clue pointing towards a possible connection between genetics, maybe even the immune system, and the disorder. A connection, by the way, that we're still exploring today.
Yeah, that's wild. And then we come to ADHD, attention deficit hyperactivity disorder. And they describe it as ongoing inattention, hyperactivity, impulsivity, and they even acknowledge that it could continue into adulthood. Now, the exact cause was, of course, still a mystery back then, but they already suspected that both genes and environmental factors were playing a role, possibly influencing brain chemicals like dopamine, serotonin, and glutamate. There's even a suggestion of a possible inflammatory component, which is interesting.
Yeah, very much ahead of its time. Recognizing multiple neurotransmitter systems might be involved, and even the possibility of inflammation, that's pretty sophisticated for 1950. It really shows how even these early observations were starting to point towards a more complex, multifaceted understanding of ADHD.
Totally. And the fact that they recognized it could persist beyond childhood, that was a big deal too, because that wasn't always a universally accepted idea back then.
Absolutely. It challenged the prevailing notion that this was just a childhood phase kids grew out of.
Right. Okay, so then they moved on to this broader category of psychoses. Severe mental and behavioral disorders. Things like delusions, hallucinations, disorganized thinking, difficulty connecting with others, paranoia, all that. They distinguished between acute and chronic forms, pointed to schizophrenia as the most common one, and sadly, they also highlighted the risk of suicide. Their list of symptoms was quite thorough, too, covering both the more obvious positive symptoms and the quieter negative ones. Reduced motivation, social withdrawal, even things like a decline in personal hygiene. Kind of sobering, thinking that even then, the underlying cause of schizophrenia was still a mystery.
Yeah, it is. And it really paints a stark picture for you, even just from this description, of how much distress and functional impairment these conditions caused. The fact that they explicitly mention suicide risk underscores the need for effective interventions and ongoing support, a need that clearly has been recognized for a very long time.
For sure. All right, so let's get into the actual agents they were using, starting with antipsychotic or neuroleptic drugs. Now, the presentation explains that typical antipsychotics, their main mechanism of action was blocking dopamine receptors. So basically, preventing dopamine from delivering its message to the next brain cell.
Like putting up a roadblock for that specific signal.
Exactly. They also noted that these drugs had an impact on the reticular activating system, or RAS, which is involved in regulating alertness. So their thinking was that these drugs could help to filter out some of that excess stimulation that might be contributing to things like hallucinations or delusions. And on top of that, these drugs had other effects too. They were anticholinergic, meaning they blocked the action of acetylcholine. They were antihistamines, blocking histamine, and they were also alpha-adrenergic blockers, which could affect blood pressure. A lot going on.
Right, multifaceted. Then the atypical antipsychotics, on the other hand, were understood to block both dopamine and serotonin receptors, different but related mechanisms.
So what were the main reasons they would actually prescribe these drugs? What conditions were they targeting?
Primarily, it was schizophrenia. That ties back to what we were just discussing about psychoses. But the presentation also mentions using them for hyperactivity, aggressive behavior, and even severe behavioral problems in children.
Wow. Okay, so pretty broad applications.
Right. That reflects the understanding back then that these drugs could help manage a whole range of disruptive behaviors, even if the underlying cause wasn't necessarily schizophrenia, more about symptom control in some cases.
Interesting. Now, the way these drugs were thought to behave in the body is fascinating. The pharmacokinetics section mentions that absorption through the gut could be a bit iffy depending on the drug and its formulation. But what really stands out is the difference in potency between taking it orally versus an intramuscular injection like night and day.
Yeah, they point out that an IM injection could deliver significantly more of the active drug into the system compared to swallowing a pill, like 4 or 5 times as much in some cases. So that difference in bioavailability likely played a big role in how they use these medications in more acute situations, where a rapid and more reliable effect was needed. They also note how these drugs can distribute widely throughout the body's tissues, some even sticking around and being released slowly over long periods, some up to 6 months.
That's a long time.
It is, and it has big implications for understanding their long-term effects.
Yeah, makes sense. And when it came to how the body breaks down and gets rid of these drugs, what we call metabolism and excretion, the liver was, the main player, byproducts leaving through bile and urine. They even noted that children tended to metabolize these drugs faster than adults and older adults slower. So that's obviously super important for getting the dosage right and avoiding those nasty side effects in different age groups. And then there's the fact that these drugs could cross the placenta during pregnancy and end up in breast milk, which raises all sorts of concerns about their use in those situations. So the presentation then lays out a bunch of situations where these drugs were not recommended. What were some of the red flags they were looking out for?
Well, there were a number of contraindications listed. Some of the main ones included underlying medical conditions that could be worsened by blocking dopamine. They were also pretty cautious about using them in older adults with dementia. Conditions that were sensitive to the anticholinergic effects, things like glaucoma, urinary retention, were also highlighted, along with seizure disorders and active alcohol abuse. They also specifically said to avoid them during pregnancy or if someone had a weakened immune system.
Wow, okay. That's a pretty extensive list.
It is, and it goes even further. They also included more specific conditions like damage to certain areas of the brain, bone marrow problems, Ray's syndrome, being in a coma, and during alcohol withdrawal. Plus, they specifically advised against using these drugs at the same time as other sedatives. So, yeah, a really cautious approach to using these powerful medications, especially in people with other health issues.
Makes sense. And given how many different systems in the body these drugs could potentially affect, it's not surprising they came with a whole laundry list of possible side effects. The presentation actually categorized these side effects based on how the drugs worked. So whether they were blocking dopamine, acetylcholine, histamine, or those alpha-adrenergic receptors. This could lead to a whole range of effects on the brain and nervous system, the cardiovascular system, and even the respiratory system. They also pointed out some really important drug interactions, especially with alcohol, medications that block acetylcholine, and drugs known to potentially mess with the heart's electrical activity. Things like ziprasidone or thiordazine.
Yeah, because these drugs had such broad effects on different neurochemical systems, the potential for a wide array of side effects was pretty significant. And you mentioned the QTC prolongation, which is a really crucial point for you to understand, because that can increase the risk of serious heart rhythm problems. And that risk is even greater when these drugs are combined with other substances that affect the brain or the cardiovascular system. So close monitoring is essential.
Absolutely. So let's break down some of the specific antipsychotic drugs they talked about, starting with chlorpromazine, also known as thorazine. Now, this is a phenothiazine, and it had a pretty hefty list of potential side effects. We're talking muscle spasms or dystonia, restlessness, what they called akathisia, anticholinergic effects like dry mouth and blurred vision, low blood pressure, also known as hypotension, a potentially life-threatening condition called neuroleptic malignant syndrome, sedation, sexual dysfunction, and a movement disorder called tardive dyskinesia. And of course, the black box warning about an increased risk of death in elderly patients with dementia-related psychosis. That's a big one.
Huge. And that warning remains in place today, and it highlights a very serious safety concern. Now, the contraindications for chlorpromazine largely mirror the general contraindications for all antipsychotics. They specifically mention avoiding it in folks with conditions like subcortical brain damage and bone marrow suppression. They did note, though, that it could be used via injection to rapidly calm someone who's extremely agitated, and even intravenously for severe hiccups. That's interesting.
Hiccups.
Really?
Yeah, apparently. They also mentioned a possible interaction with St. John's wort, which could increase the risk of dystonia. And it was classified as a pregnancy category C drug, meaning there's not enough information to say for sure whether it's safe during pregnancy. Oh, and one more thing. They noted that a medication called Cogentin could be used to manage some of those movement-related side effects, especially in cases of overdose.
Good to know. Yeah. Okay, next one is haloperidol, or Haldol, which is not a phenothiazine. They use this for things like Tourette syndrome, aggression, and extreme excitability in children. And unfortunately, it shared a similar list of potential side effects and that same black box warning as the phenothiazines. But one difference here was that it could be given as a long-acting injection. Effects could last for like 3 weeks after a single shot. Yeah, that long-acting injectable form was a big deal for helping some patients maintain more consistent medication levels, which can be crucial for managing their condition, especially if they have trouble remembering to take pills every day. Now, some of the specific situations where haloperidol was contraindicated included Parkinson's disease, seizure disorders, alcoholism, severe depression, and there were potential interactions with medications like lithium, phenobarbital, levodopa, and beta blockers. They also warned about potential severe reactions if the drug was stopped abruptly.
So taper off slowly.
Exactly. And while it was noted to cause less sedation and low blood pressure compared to the phenothiazines, it did have a higher risk of those extrapyramidal movement disorders we talked about. And again, pregnancy category C. Not enough data to say definitively.
All right. Well, speaking of adverse reactions, the presentation goes into some detail about neuroleptic malignant syndrome, or NMS, and extrapyramidal symptoms, or EPS. They described NMS as a serious medical emergency, with symptoms like high fever, excessive sweating, unstable blood pressure, difficulty breathing, incontinence, muscle rigidity, really scary stuff.
Absolutely. Potentially fatal, needs immediate medical attention. And then you have the different types of EPS dystonia, which is basically sustained muscle contractions, tardive dyskinesia, with those involuntary movements, often of the face and tongue, akathisia, that feeling of inner restlessness, like you got to move all the time. And then pseudo-Parkinsonism, which mimics the symptoms of Parkinson's disease. It's clear that these were major concerns with these older antipsychotic medications.
For sure. Then, rounding out the antipsychotics, they touched on the atypical antipsychotics, specifically risperidone, also known as risperidol. The big selling point here was that it aimed to treat both the positive and negative symptoms of psychosis, hopefully with fewer of those dramatic side effects. It was also mentioned as a possible treatment for irritability in children with autism.
Right. It was seen as a potential game changer, a way to address a wider range of symptoms with better tolerability.
But of course, it still had its own set of potential side effects. Weight gain, metabolic issues like high cholesterol and blood sugar, EPS, fatigue, nausea, vision problems, and just like some of the older antipsychotics, it was also available in a long-acting injectable form. And it carried that same black box warning regarding elderly patients with dementia-related psychosis.
Yeah. Sadly, those metabolic side effects, the weight gain, increased risk for diabetes, those became significant new concerns that needed to be carefully managed. And there were several specific situations where risperidone was not recommended. Things like cardiovascular disease, history of seizures, suicidal thoughts, kidney or liver disease. And they strongly advised against mixing it with alcohol, antihistamines, sedatives, and another antipsychotic called clozaril. And from a nursing perspective, they highlighted the importance of avoiding any overlap with other antipsychotics and being aware of potential increases in liver enzyme levels. And, you guessed it, pregnancy category C.
The mystery continues. All right, let's shift gears to drugs used for bipolar disorders. The presentation kicks off with a little overview of bipolar itself, highlighting those alternating episodes of deep depression with the low energy, the changes in sleep and appetite, and then the manic episodes with the grandiosity, reduced need for sleep, rapid speech, racing thoughts, distractibility, and risky behaviors. Sounds exhausting.
Absolutely, it can be. And then they jump into lithium, or lithobid, which of course has been a mainstay of treatment for bipolar for quite a while. They break down its actions, noting that it messes with sodium transport in cells, inhibits the release of norepinephrine and dopamine, but interestingly, not serotonin, and it also influences certain signaling molecules inside cells. However, they admit that the exact way it worked to reduce mania, even back then, was not entirely clear.
A bit of a black box even then.
Yes, exactly. Lithium's mechanism of action is complex and, honestly, continues to be an area of active research even today. Its effects on multiple neurotransmitter systems and intracellular signaling pathways really speak to its broad impact on brain function. And how the body handles lithium is also quite specific. It's readily absorbed, distributes throughout the body much like water, but it crosses the blood-brain barrier slowly, which can actually delay the onset of any toxic effects. And it's primarily eliminated by the kidneys with significant reabsorption. But, critically, it can cross the placenta and enter breast milk, potentially posing risks to a developing fetus. So yeah, definitely a major safety consideration.
For sure. And the reasons to be cautious or even avoid lithium altogether, the list is pretty long. Includes hypersensitivity, of course, significant kidney or heart disease, history of leukemia, metabolic disorders, dehydration, pregnancy, and breastfeeding, any condition that could affect sodium levels in the body, even infections with a high fever. And the side effects they list, often linked to those sodium level changes: headache, feeling tired or weak, memory issues, and stomach upset. They even specifically say it's important to keep your salt intake consistent.
Right, because maintaining that stable sodium balance in the body is crucial when you're on lithium. The kidneys handle both sodium and lithium in a really interconnected way. So anything that causes the body to lose sodium can lead to higher lithium levels and increase the risk of toxicity. And that's a big deal because lithium has what we call a narrow therapeutic window, meaning the effective dose range is pretty small, and even a little bit too much lithium in the blood can cause significant side effects, especially on the nervous system, heart, and kidneys. Levels above 2.5 millieql can be life-threatening due to widespread organ damage. So that narrow window is exactly why regular monitoring of blood lithium levels is so essential.
Wow, so it's a really powerful drug that needs to be used carefully. And the potential for interactions with other medications, also something to be super mindful of. The presentation lists a bunch of drugs that could potentially interact, including haloperidol, neuromuscular blockers, carbamazepine, thiazide diuretics, drugs that make urine more alkaline, indomethacin, some NSAIDs, even psyllium, a fiber supplement.
Yeah, that just emphasizes how important it is to do a really thorough review of all the medications a patient is taking when you're considering lithium. For example, thiazide diuretics, they can cause the body to hold on to more lithium, increasing the levels, and NSAIDs can also interfere with how the kidneys clear it. And the interaction with haloperidol raised concerns about potential neurological side effects.
Okay, so a lot to consider there. Now, the presentation does mention some safer alternatives to lithium, suggesting that anticonvulsant medications like valproic acid and atypical antipsychotics like risperidone might be more effective and have fewer of those tricky issues, and you wouldn't need those frequent blood tests. But they do point out potential side effects for these alternatives too.
Oh, and there's a quick little question to check for understanding. It asks about lithium's main action, and the correct answer is that it inhibits the release of norepinephrine and dopamine. Just a little knowledge check there. Yeah, and the emergence of anticonvulsants and atypical antipsychotics as alternatives to lithium. That was a big step forward in how bipolar disorder was managed. It gave clinicians more options and potentially better tolerability for patients. More tools in the toolbox, so to speak.
For sure. All right, let's move on to the medications used for ADHD and narcolepsy. So the presentation explains that CNS stimulants, they likely work by increasing the release of certain brain chemicals called catecholamines, which basically enhance stimulation in the brain. And then the amphetamine stimulants, they have this additional effect of blocking the reuptake and increasing the release of norepinephrine and dopamine. And the primary conditions they were using these for: ADHD, narcolepsy, and certain other sleep disorders.
Makes sense. They're targeting those dopamine and norepinephrine systems in the brain, which are believed to be really important for attention, wakefulness, impulse control. The fact that they're rapidly absorbed from the digestive system, metabolized by the liver, and then excreted in urine, that's all part of understanding how they work in the body. Pretty straightforward pharmacokinetics.
Yeah, but just like the antipsychotics, these stimulants came with reasons why you might not want to use them. Allergies, significant anxiety or agitation, glaucoma, heart disease, history of seizures, drug dependence, pregnancy, breastfeeding, and of course, a whole slew of potential side effects: brain and nervous system, gastrointestinal issues, cardiovascular effects, skin rashes, and even various drug interactions, especially with MAOIs, TCAs, caffeine, and even some over-the-counter cold meds.
Right, and those potential cardiovascular and neurological side effects, those are nothing to sneeze at. That's why careful screening and ongoing monitoring of patients on these meds is so crucial. And those interactions with MAOIs, those can be really serious, leading to a dangerous spike in blood pressure. And then you have the whole issue of drug dependence and the potential for misuse and addiction, which sadly we still grapple with today.
Absolutely. So the presentation then goes on to quickly touch on some key features of ADHD, like distractibility, difficulty following instructions, problems with focus and memory, impulsivity, sometimes sleep disturbances. And then they zero in on methylphenidate. So Ritalin, Concerta, it was described as helping to increase alertness and focus, but man, that list of potential side effects: insomnia, nervousness, loss of appetite, weight loss, irregular heartbeat, high blood pressure, even liver problems. And it carried a black box warning due to its high potential for abuse and the risk of sudden death or serious cardiovascular events if misused, especially in people with a history of drug dependence or alcoholism.
Yeah, that black box warning for methylphenidate, that's a major safety message.
Yeah.
It emphasizes the need for careful prescribing, close monitoring, because the potential for misuse and the cardiovascular risks are just not something you can ignore.
Definitely. And they list a number of conditions where it was not recommended: significant anxiety, agitation, psychosis, suicidal thoughts, glaucoma, motor tics, things like Tourette's. So a thorough evaluation before starting treatment is crucial. And as a Schedule II controlled substance, its prescription is subject to pretty strict regulations.
Rightly so.
The presentation also mentioned that it could decrease the effectiveness of anticonvulsant medications and should not be used with MAOIs or antihypertensives. And then they mentioned this idea of taking periodic drug holidays, maybe to help manage side effects or reassess whether the medication was still needed. And no surprise, pregnancy category C.
Yeah, the ongoing mystery of whether it's safe during pregnancy.
Oh, and there's another little true-fault knowledge check. This one asks if CNS stimulants are indicated for ADHD, narcolepsy, and binge eating disorders in adults. And the answer, according to this 1950 presentation, is false. Although they do mention that a related drug was later approved for binge eating disorder, but of course with those specific warnings about the potential for abuse.
Right, and that just goes to show how medical knowledge and those approved uses for medications can change over time. As we learn more, things get updated, new applications are discovered, new risks identified. It's a constantly evolving field.
Absolutely. All right, so last but not least, we have medications for anxiety and insomnia. They start off by outlining the different types of anxiety disorders, and then they give this brief overview of the neurobiology involved, mentioning the limbic system, the hypothalamus, the reticular formation, the reticular activating system, or RAS, and their roles in things like emotions, arousal, and the sleep-wake cycle. And they suggest a possible connection to anxiety. Makes sense.
It does. And this early understanding of those brain regions and how they connected to each other, that was a fundamental step in understanding the biological basis of anxiety and sleep disorders. Not just psychological phenomena, but something happening in the brain.
Right. And they talked about insomnia, noting its connection to anxiety and other conditions. They also mentioned the risks of experiencing worse insomnia after stopping sedative medications, something we call rebound insomnia, and the increased risk of medication-related sleep problems, especially in older adults. They really emphasized trying those non-drug approaches first.
Yeah, that focus on non-pharmacological treatments like CBT, counseling, relaxation techniques, it really reflects a more holistic view of how to manage these conditions.
Yep.
Even back in 1950, it wasn't just, here's a pill, problem solved. It was about addressing the whole person.
For sure. And when medication was deemed necessary, they talked about using CNS depressants, which could include antidepressants, benzodiazepines, barbiturates, and other anxiolytics. And they noted that the effects could range from like simple relaxation all the way to a coma, depending on the drug and the dose. They highlighted antidepressants, specifically the older TCAs and MAOIs, and the newer SSRIs and SNRIs as the main treatments for both depression and many anxiety disorders.
Yeah, each of those classes of antidepressants, they target different neurotransmitter systems,
Mm.
offering more options for addressing those underlying chemical imbalances.
Exactly. And they specifically mentioned escitalopram or Lexapro as an SSRI, phenelzine or Nardil as an MAOI, with its well-known dietary restrictions, amitriptyline or Ilavil as a TCA, with those warnings about potential heart problems, and venlafaxine or Effexor as an SNRI, which was seen as having fewer side effects in some areas compared to the older antidepressants.
So more tools in the toolbox, but each with its own set of potential benefits and risks. Careful consideration was key.
Totally. Then there were benzodiazepines, like lorazepam, also known as Ativan, which were described as increasing the effects of the neurotransmitter GABA. They were used for anxiety, insomnia, seizures, alcohol withdrawal. But big caveat, they came with those significant risks of drowsiness, slowed breathing, and the potential for dependence.
Yeah, that potential for addiction and those respiratory risks really led to a much more cautious approach to using benzodiazepines over time, with a greater emphasis on finding safer alternatives whenever possible.
And then barbiturates, like phenobarbital, also known as luminol, were mentioned as being rarely used for anxiety or insomnia anymore, mainly because of those serious side effects. The development of tolerance, respiratory depression, not ideal.
Definitely not.
And finally, the presentation briefly touches on the general approach to caring for patients who are on any of these psychotherapeutic medications. They really emphasize the importance of assessing their physical and mental health, medication history, any potential risk factors, that whole holistic approach.
Right. It really underscores the need for a comprehensive approach to patient care. Not just prescribing a pill, but really monitoring for the intended benefits, being vigilant about potential side effects, and providing really thorough education to patients about their treatment, shared decision-making, good communication, all that good stuff.
Exactly. Wow, we really went deep on this 1950 presentation. It's amazing to see how those early understandings of mental health conditions and their treatments were taking shape.
It is, isn't it? Like those initial ideas about chemical imbalances and the roles of specific neurotransmitters really laid the groundwork for so much of what we understand today.
And think about how our knowledge has just exploded since then. We have these incredible brain imaging techniques, genetic research, a so much deeper understanding of how the brain actually works.
Yet, it's amazing how many of those fundamental concepts they were exploring back then are still relevant. They still inform how we approach treating mental health conditions even today. It's like building upon those early insights.
It is. This whole deep dive has really highlighted the constant evolution of our understanding of the brain and mental illness. And while our tools and medications have obviously advanced dramatically since 1950, the underlying goal remains the same: to help people who are struggling with these often very challenging conditions to live better, richer lives.
Couldn't have said it better myself.
So, reflecting on this journey through the past, it's pretty remarkable to think about that delicate balance involved in using these agents. It's not about curing the disorder necessarily, but about improving quality of life. And always, always being mindful of those potential side effects. It's a complex equation with so many variables. So this leaves us with a question for you listeners to ponder. As our knowledge of the brain and mental illness continues to advance, what kind of truly innovative approaches and therapies might we see in the future? Ones that go beyond simply managing symptoms and actually target those root causes of these complex conditions in ways that we can only imagine right now. The future of mental health treatment is full of possibilities, and that's pretty exciting.
It is. There's so much potential out there and so much more to learn.
Exactly. So keep those brains curious, folks, and we'll see you on the next deep dive.